ask you a question, sir?
Please.
I'm a little confused, after seeing your slides, regarding the agonist, long agonist, short agonist, and antagonist.
Yeah.
We all believe that, in a patient with poor responders, one should use antagonist cycle. But your results are showing that a long agonist is giving little edge over the antagonist. Is that right?
It shouldn't be confusing. That is because we made an assumption that ovarian suppression before stimulation is bad. That is the wrong assumption, because if anything, it provides some degree of hypogonadotrophic hypogonadism, which is expected in some way to sensitize the ovaries for stimulation. But however, none of these were statistically significant. They were comparable, but there is nothing that more or better than the other. The short agonists, where we used to think because of the flare effect it could have advantage, it proved not to be the case. And the only explanation I have for this, because the initial flare, as far as LH is concerned, it could create more progesterone, and progesterone could be detrimental to endometrial receptivity. Yeah.
What is your preferred protocol when the patient first comes? Which is the protocol you use?
Always have the long agonist as my preferred protocol for any patient starting afresh.
Yeah, even
No
above
matter
40.
whatever profile the patient has. Yeah.
Any questions?
The question I would ask, because I'm an endoscopic surgeon,
Yeah.
and I feel very upset when I see these ectopics in IVF.
Yes.
You have a method of preventing them? It's very upsetting for the patient. She's gone through so much of cost.
Yeah. I think
And
we can,
especially in India.
we can help in that front. If a patient has hydrosalpinx, there is temptation to do salpingectomy without due care. And if you leave a tubal stump, that will be still good reason for ectopic to occur. That is one. The second one, if when you do your embryo transfer, you do it under ultrasound guidance, and do it so gently without creating uterine contractions, you could reduce the incidence of ectopic, because those uterine contractions can pull the embryos up, and in a scar tube they may not come back. These are subtle issues, and in our own program, our ectopic rate is around 0.7%, which is relatively low. Other people reported as high as 3%.
Dr. Khalaf, I just want to ask you, since you've said your preferred protocol is a long protocol even in poor responders and elderly women, what is your experience of using, when you use recombinant gonadotropins, do you believe in adding recombinant LH in the later part of cycle in these women?
No. 90% of our patients use recombinant FSH straight away, and we have done this since 1996.
But
we are engaging in a randomized control trial, multi-center, multinational, about 52 centers, just starting early next year, where we will add LH in a randomized control trial. Personally, I'm not holding my breath.
Okay, thank you.
So the role of AMH, AFC, and FSH-E2, which one would you give most importance, or is it all of it together?
Again, if we are on the side of patient and if we are practical, I would always go with antral follicle count. It is very simple to measure. No IVF clinic will run without having transvaginal ultrasound scan, and all it requires is just 2 minutes examination. People make it sound as if it is rocket science. It isn't. It's very simple. You are either seeing solid ovaries where they have 1 or 2 follicles, you know you are up against it. Or you are seeing ovaries that are full of follicles, whether they are PCO or multicystic, you know that you need to be careful, and the expectation to produce high number of eggs, high risk of hyperstimulation, and anything in between. There is nothing so clever about it. Bringing the patient on day 2 to 4 can be challenging, proper timing. Getting the patient to pay the expenses for AMH may not be justified. So if I am to select any ovarian reserve test, it has to be antral follicle count. Yeah.
And any cutoff of FSH beyond which you'd not offer stimulation?
No, for as long as the patient has regular cycles, no FSH level will stop me trying. But when it is high, I will tell the patient, we will give you a try, but I will not rely on her FSH. I will done the AFC. You have 3 or 4 follicles. The expectations are limited. You will be investing 5,000–6,000 pounds. You will be having a chance of 10%. You happy to make that emotional and financial investment for that so little return? And we introduce in the conversation the alternative of donor eggs. Some people will go for trying first their own before egg donation. Some people will take egg donation with open arms.
One more question, sir. Sir, can I ask?
There is no need to use 3D ultrasound, really. It doesn't add value. Because also, some people go very academic. You have a patient who has antral fold count of 35. I wouldn't worry and measure and even count them. We know that this is a busy ovary. Above 20, there is nothing to make you spend ages measuring every single one. So it is a bit of clinical judgment and consideration. So there is no need also to make it complex by doing 3D.
Excuse me? Is it actually follow-up of your previous talk regarding the recurrent implantation failure? When do you write off your patient? A young patient who's tried 3 times, 4 times, before you write her off that you go for an adoption?
I wouldn't write anybody off.
So how many cycles? You keep on going for how many
My
cycles?
motto is, for as long as there are embryos to go back, there is a chance. The key word is resilience. If the patient is resilient, financially and emotionally, I will keep trying. And you can see it happening to patients after 5, 6 times, and some of them, even in between, she will fall pregnant naturally.
Okay, thank you.
Thank you, Dr. Khalaf.
Thank you.
That was a wonderful
Excuse
talk.
me?